very welcome, everybody. Please let me start my 12-month progress. My PhD topic is the surgery of the pelvic organ prolapse and female stress urinary incontinence. My name is Júlia. I'm a PhD student and a resident doctor at the Urology clinic. My mission is to reduce the complications of the pelvic organ prolapse surgeries, and my mission is to formulate the recommendations for the surgical treatments in terms of the indication, contraindication, and patient selection. We have 2 ongoing projects which we are working on, and 3 other which we would like to work in the near future. The first one is investigating the safety and efficacy of the female pelvic organ prolapse surgeries with versus without vaginal implants. 1 in 2 women over the age of 50 have a certain extent of pelvic organ prolapse. Around 11% of the women have surgery for POP by the age of 80. And in many cases, an implant surgery is required to treat the disease. However, there are some implant-related complications. On the other hand, with the vaginal implants, we can achieve an excellent anatomical correction. The increasing number of the complications was the reason why FDA has issued several warnings regarding the safety of these surgeries, and several countries completely banned the use of vaginal implants. But the guidelines are different and the recommendations are not clear now. This was the reason why we would like to compare the safety and the efficacy of the female pelvic organ prolapse surgeries with versus without vaginal implants. The question is whether there are any differences regarding the complications and the efficacy between the patients who undergo these surgeries with or without implants. The population was females who undergo pelvic organ prolapse vaginal surgeries. The intervention was the surgeries with implants compared to surgeries without implants. The main outcome was the complications, and the second outcome was the efficacy, which we mean anatomical success. We used the population and the intervention and the search key, and finally 77 articles were eligible. We categorized the outcomes for complications and for the efficacy, and we broke down the complications for the functional and non-functional ones. First of all, I would like to show the non-functional complications which we analyze with the multivariate analysis. I would like to highlight the erosion, which is much higher in the implant group, of course, because it is an implant-related complication. And the bleeding, which we mean vaginal bleeding, was also higher in the implant group, but it's connected to the erosion in many cases. For the functional complications, de novo stress urinary incontinence was higher in the implant group, but it's because of the technique of the surgery. And we analyze the efficacy of the 2 techniques, and with vaginal implants we can achieve better anatomical correction, and the prolapse won't come back in the follow-up time. The median follow-up time was 1 year. We analyzed the reoperation rates, the reoperation due to complication, and the efficacy also. First, I would like to show the reoperation due to complication. In case of the RCTs, the reoperation rate due to complication was 2 times higher in the implant group. However, the reoperation due to recurrence was higher in the native tissue group. So with the implant technique, we can achieve better anatomical results. The strength of our analysis, it was an extensive analysis of all complications with high-quality studies on a large population, but we have some limitations, of course, which was the rare events and the heterogeneity, which based on the different vaginal implants and the different vaginal compartments, for example. The conclusion of our analysis is pelvic organ prolapse surgeries with vaginal implants are more effective procedures, and the reoperation due to complication rate is acceptable, and the difference is clinically not relevant. The leading complication is erosion. For the clinical practice, we should revise the use of vaginal implants. We should feed the guideline for the daily practice, and we should select the best target population where we can perform the implant surgeries. For the research, we need more well-designed RCTs, and we need to analyze the prognostic factors of the complications. We finished the manuscript and we submit to the European Urology. Actually, yesterday we got the feedback and the article was rejected. However, the comments from the reviewers was absolutely positive, and we got some very good criticism, which we will consider before the next submission. And the second project is investigating risk factors associated with erosive complications after pelvic organ prolapse vaginal surgeries. Based on our previous analysis, now we would like to identify the causes and the prognostic factors which predisposing to mesh erosion after vaginal implant surgeries. The question is, which is the subpopulation of the patients who should not undergo this type of surgeries? The population was females who undergo pelvic organ prolapse surgeries with implants. We analyzed the risk factors like age, menopausal status, obesity, smoking habits, and so on, and the outcome is the erosion. We would like to decrease the erosive complication rates and increase the safety of these surgeries. Our hypothesis is there are specific risk factors which are associated with the mesh-related erosive complications, and we would like to identify the potential factors, and with this identification we can reduce the occurrence of the erosion rate. We use the population and the outcome in the search key, and after the title and abstract selection, 168 articles were eligible, and we nearly finished the full text selection, but we don't know the exact number now. Yes, and we have a third project, which is investigating the risk factors associated with complications of female stress urinary incontinence surgeries. The prevalence of the female urinary incontinence varies 11 to 60%, and the majority of the cases is stress urinary incontinence. However, the guideline recommend to use the mid-urethral slings with a high level of evidence. FDA has issued several warnings regarding the safety of the stress urinary implant surgeries because of the high complication rates. Some countries partially limited the use of these vaginal slings, not only in case of the pelvic organ prolapse surgeries, but also the female stress urinary incontinence surgeries. So we would like to identify the causes and the risk factors predisposing to complications of the female stress urinary incontinence surgeries. The question is, which risk factors can influence the complications associated with female stress urinary incontinence sling surgeries? The population is females who undergo these mid-urethral sling surgeries. We would like to analyze the risk factor, and the outcome is the complication rates. We would like to decrease the complication and increase the safety of these surgeries. Our hypothesis is the mid-urethral slings are still safe and effective procedures to treat the female stress urinary incontinence. And there are some correlation between the risk factors and the complications. We use the population and the procedure in the search key, and now we finished the Prospero, but we haven't submitted yet. To summarize the progress, we submit the first article, and it was rejected, and we submit another paper, and the second one we would like to go on with the full text selection and the data extraction. Thank you so much, and please let me close the presentation with a quote from Michael Jordan: "Never say never, because limits like fears are often just illusions." Thank you.
May I ask, regarding your second topic, what are the most important risk factors for erosion? And I'm very curious about the criticism of the revisers, so maybe you can tell us something about the first topic, what they said or what they wrote. Thank you.
Yes, thank you so much. The nice questions. For the second topic, it depends on the level of the risk factor, because it's not. It is important to know that the obesity at which level. So maybe we can make categories, and for example, the age is also important, and maybe we will identify a cutoff value, which above we do not recommend this type of surgery. So it depends on the level of the risk factors, I think. It's totally individual. And for the comments from the reviewers, one of the main comment was the implant types was so important, and we do not calculate with the analysis. Actually, we collect the implant types, but in many cases, the articles use many types of implants, and they just mentioned it all types, and we don't know how to calculate with this. It is statistically not observable. Yeah.
Sorry, is it a daily routine? So do you use mesh implants nowadays, despite of the complications in your clinic?
In some selected cases, we use with pelvic organ prolapse. So, for example, if the woman is no sexual activity, and we calculate the risk factors in our practice, and we use some cases, yes.
And do you use it as a first-line therapy in some cases?
The first-line surgical therapy, yes. In some cases, yes. Because before the surgery, we try to treat this disease with conservative way, and if it's failed, maybe we can operate, and in some cases we use. But it's we decide to use this mesh during the surgery sometimes. So we try to feel it. It's enough to use a native tissue repair, or it's not enough, and we should use sling or a mesh.
Thank you very much.
Thank you.
Thank you. This is just a comment that.
Okay.
So your paper was rejected. Actually, you should be happy, because then you are at the top. I mean, you are rejected by a top journal, so don't worry about that. I'm telling this to the others too. I mean, that happens many times, even to Peter Hegyi. I mean, that happens. You see that there are papers rejected. So just keep working on that, all of you. The specific question is that how do you proceed now? So what's the next step? What are the next steps?
The next step, yeah, we would like to consider the comment, because it's great comments. So it was a very detailed revision with great minor comments. So we will consider it, and we would like to submit the article to the European Urology Focus, maybe. It is also a D1 top urology journal, so we hope that it will be.
Just a comment with Gabor, I completely agree with you. So this is the journal, so as you can see, urology is not the biggest topic, but although that it has a 24 impact factor journal. Yeah. So it is like a dream, but unfortunately the reason why it has so high impact factor, because most likely they publish guidelines, and very, very selected cases, especially very much most likely in uro-oncology. So we are not extremely surprised. Anyhow, with that congratulations, that is great comments on it, so that we can work on it, and I'm definitely sure it's gonna be fine.
Yeah.